Bueno, antes que nada agradecerle a los presentes y a los que están por Zoom la participación. Tengo el gusto de presentar al doctor Francisco Laurindo. El doctor Francisco Laurindo, que nos acompaña por Zoom en este momento desde San Pablo, se formó en la Universidad de San Pablo, donde actualmente es el director del laboratorio de biología vascular y es profesor asociado de esa institución. Es el profesor asociado de cardiología y es el chair del laboratorio de cirugía vascular. El profesor Laurindo tiene una vastísima trayectoria con una importantísima formación de recursos humanos, más de 200 artículos publicados en Scopus, con un índice de impacto cercano a 50, con un desarrollo, por lo que entiendo, en medicina transnacional, que nos va a iluminar sobre los nuevos desembarcos que puede haber desde el laboratorio hacia la clínica. Y después de su presentación, el profesor Radi, que por todos conocido, profesor de bioquímica y director del Centro de Investigaciones Biomédicas de la Facultad de Medicina de UDELAR, miembro de la Academia Nacional de Medicina y presidente de la Academia Nacional de Ciencias, con más de 300 artículos publicados también y con un índice de casi 100, por lo que revisé hoy de mañana. Así que los bienvenidos, profesor Laurindo, lo escuchamos.
Muchas gracias. Yo los peço desculpas por hablar em inglês, porque não me sinto muito confortável com portunhol. It's really a great pleasure to be here. I'm honored to speak to you and to discuss some aspects of our thoughts about how to develop the future of medicine. So I'm going to share my screen. Hopefully it's going to work. Let's see. Can you see it? Okay. So the future of medicine, and we will focus today on the basic science, how we come from basic science to clinical developments. And so here, just explaining to you some symbols here. INCOR is our institution, our lab, and the Redoxoma is the group in which we work, and it's financed by several agencies, particularly FAPESC. And this already tells you that I have a very strong connection to basic sciences. And today, when I thought about speaking in the future of medicine, I tried to think, okay, what is futurology? I don't want to make futurology as an exercise of the expected. But nevertheless, I did start with the question of what is expected in the future of medicine. And to answer that, there is a very good tool nowadays, which is ChatGPT. So I asked ChatGPT what it thinks will be the future of medicine, and this is its answer. The future of medicine is a dynamic landscape shaped by technological innovations, so it's heavily biased to technology. It talks about personalized treatment, genomic medicine, wearable devices, real-time health monitoring technologies, artificial intelligence and AI-powered robotics, nanotechnologies for drug delivery and diagnostics, and telemedicine and digital health records. I think all this has somehow touched us, and nevertheless, ChatGPT forgot one of the most important issues, which is that first, we don't know enough, let's say. And that's the first thing I would like to leave to you, a message that nowadays we talk a lot about future of medicine, but we don't really incentivize students to get to questions about how can I treat better our patients. Sometimes they are satisfied with the guidelines. So if I apply the guidelines, everything is okay. So does this the code and stone, written in stone, truth, the guideline that I have to do. And I've seen this more and more nowadays, and I think we need to incentivize our students and youngs to be real rebels, let's say. We don't know enough. We need to get better treatments to our patients. So this is the first thing that ChatGPT and other common ideas do not comment. And the second message that I'd like to leave to you is that all the cycle of research lies on basic science. And when I tell basic science, it's basic science at large, including epidemiological studies, data science, biochemistry, systems biology, physiology, etc. So all this all this is really important to incentivize us to go to the state of disease mechanisms, which will allow us the identification of therapeutic targets, and then will foster us to do iterative translational investigations, which will lead us to clinical studies, and which will eventually lead to the development and implantation of new therapeutic agents, procedures, or technologies, and which then have to be applied to the population at large. And then we have a problem of adherence to all these, which brings us back to the start of the cycle again, because new relevant problems are identified not only by appearing clearly, but also by clinical observations and epidemiological studies. And the cycle repeats itself really hundreds of times. So there are two things I'd like to point here. One is that there is the death valley here that's called by the industry. So this is a point we don't have time to talk today too much, but it's a very important place in which many ideas die. So you have interesting ideas, interesting mechanisms. You do the iterative translational investigations, but then the intervention fails to achieve success in clinical studies. The second point that's important is that disease mechanisms act as a continuous feed-forward source of life, let's call it, to medicine. And there is a very important discussion of whether this stage of investigation should be curiosity-driven or mission-oriented. So the financing agencies discuss a lot whether should we allow people to drive their own research, or should we tell them to go to specific points. We have just got out of a pandemics, and there we had a very clear case to do mission-oriented science. We need a vaccine, we need several procedures to prevent disease. But in general, curiosity-driven science is also very important, because otherwise we don't open the scope of possible alternatives to understand mechanisms. And I actually gave ChatGPT another chance and asked it to, what is the role of basic science for the future of medicine? And again, it answered as expected. Basic science serves as the cornerstone of medical progress, providing the essential knowledge needed to address current health challenges and anticipate future ones. Its role in shaping the future of medicine is indispensable. I'm saying this because this is what many people think, but it's not at the top of their minds, exactly as reflected in these excerpts from ChatGPT. So it's important that this continuum of research stays at the top of our minds. So I don't think it's appropriate to say basic research, translational studies. I think it's all a continuous, like basic research, translation to clinical studies, patient-oriented clinical research, translation to healthcare practice, and improved health outcomes. All this is a cycle that has to be looked at as a whole. So if one part of it fails, the whole chain is not sufficiently effective. So the second message I leave to you today is that basic curiosity-driven or mission-oriented science matters. And just to tell you an example, look at the strategic plan for the NIH, in this case, the National Heart, Lung, and Blood Institute. They have 3 goals, and none of them has to do with any specific disease or mission, but all of them have to do with understanding mechanisms of disease. I don't want to extend too much on this, but look at, for example, Goal 1, to improve the understanding of molecular and physiological bases of health and disease. Goal 2, to understanding the clinical mechanisms of disease. And goal number 3, to generate an improved understanding of the processes involved in translating research into practice and use. So that's the Death Valley that I talked to you, and other important issues related to it. So this is a very interesting example of very important mechanism that came out of curiosity-driven science. This is a Brazilian investigator, Sergio Ferreira, and he studied a potentiating factor of bradykinin, which had just been discovered by that time in the venom of a snake, Bothrops jararaca, and then he essentially discovered ways to inhibit angiotensin-converting enzymes. So the single paper of which he was studying venom, the cobra venom, was the basis for the development of angiotensin-converting enzyme inhibitors, which were a revolution in the treatment of hypertension and heart failure. Well, I could give you hundreds of examples, for example, X-ray or something like that. But instead of that, I will go to the third message of today, which is that a mechanistic mind will be more and more necessary for excellence in medical practice. And I think this is perhaps the most important message I will leave with you today, because I feel that medicine is getting very complex, because we are digging deeper into molecular mechanisms. And then if we don't understand about them, we will essentially don't know how things work. So most of the popular ideas about the future of medicine, and this is seen in this big cover of Time, this is very recent one, they deal with technology, breakthroughs, artificial intelligence, new hopes and robotics and so on. But you can see that clearly, very clearly, technology really allows us to do marvelous things, like, for example, mapping the brain circuits. So each one of this pathway has been mapped. Sorry. And this is the type of study that is becoming more and more evident nowadays with new technologies. And this is allowing important discoveries in neuroscience, which is one of the forefront fields in science. And one second example is the type of study that will become very important, which is the study of markers using omics technologies, proteomics, lipidomics, genomics, metabolomics, etc., In this case, see how proteomics and lipidomics improve the cardiovascular risk prediction in heart disease. There's a very interesting study, recent study, showing that the predictive value here in the lower left corner, you can see the clinical risk score alone, and at the right, if you add proteomics and lipidomics markers, you significantly improve the capacity of risk prediction. So this is the type of study that will be more and more prevalent. But you know how many important concepts you have here. So omics technologies, statistics, risk prediction, mechanisms of disease, molecular biomarkers. So all this add a lot of complexity. So the conclusion is that technology advances are essential, but not enough. You get to go to mechanisms. So accurate tools are important for advancing medicine, but one should care about knowing mechanisms of disease, how diagnostic tools work, and what exactly a new treatment is about. So this is an important point for us to incorporate to ourselves and to teach our students. The majority of students nowadays are too much focused on understanding guidelines. And once they understand guidelines, they put themselves into a comfort zone and they refrain from advancing in understanding, for example, pathophysiology and mechanisms of a pharmacological agent or how a molecular mechanism works. And this is something that is becoming more and more deficient because things are getting too complex. So what is a meaningful mechanistic insight? That's not easy to define, but perhaps a good definition is a good mechanism is one that adds significantly to our capacity to operate cause-effect predictions in the system being investigated. And this is one of the most interesting outcomes of knowing mechanisms, is the capacity to understand better cause and effect, because causality is some very difficult concept, is a very difficult concept, because statistics don't give us causality, it gives us association. Cause-effect predictions are a much more difficult issue than only finding statistical associations. And this has to do with our own limitations in reasoning in science. So, for example, take a conceptual fact here in the left upper corner, truth, let's call it conceptual truth. And then when we make a question about this, we are already losing something. We are imprisoning some of it. Then we make an investigational question. We start a method and we somehow imprison it a little bit more, and we have a result. And then we interpret this result and then we publish it. So at the end, the operational truth based on that hypothesis has lost a lot of its real truth. So when we only memorize the guidelines, which are the upper right corner, we lose more and more of the upper left corner, which is the true clinical concept behind that. So this is really an important point that we should keep in mind. Actually, this has to do with the Heisenberg principle, which is he's a physicist that said, what we observe is not nature itself, but nature exposed to our method of questioning. So that's exactly what the concept we have is not real truth. It's what came out of the study that we designed. So we need to incorporate that and teach it to our students. So more and more excellence in biomedical research will be the search for mechanisms and not purely description of phenomena. And more and more also the capacity to investigate across distinct systematic levels of regulation, for example, from in vitro to protein complexes to subcellular physiology, cells, etc., tissue, organs, organisms. So we have to have the capacity to go and I think the medical professional has a unique capacity to be very profound in the going through all those systems, but they have to be educated to that, and we have to educate ourselves for that too. A very important point that I see today is when we talk about the transition from basic science to clinical applications is the application to preclinical or clinical models at the precise moment. I've seen many things that went to clinical tests much before they should have gone. For example, stem cells. Many stem cell studies were too premature. They were applied much before we had real good evidence from basic studies and from iterative studies in translational models. Another important mindset we need to have is quantitation. We are, as physicians, we are highly qualitative, but we need to be quantitative, not only for medical practice, but also for starting to understand more and more of the mechanisms. For example, this is a very interesting article, Key Numbers in Biology, and I do recommend that we read that because there are things that are kind of obvious when you talk, for example, signaling proteins. We are talking about things that happen on the nano to micro molar level. So if you give a drug, for example, usually the drug is applied at millimolar level. So it's much above that of the signaling protein. So sometimes drugs are much in excess of their targets. So we have side effects and we have other issues that we need to consider. So it's important to think quantitatively. Otherwise, we are really close to make mistakes in interpretation of several studies. Another important thing is that a non-mechanistic mind tends to divide things in good or bad. But actually there is nothing either good or bad. It depends on the context. And I'll give you a short story from my own field, which is the redox and inflammation story. So we study oxidative stress in our laboratory, which is in vascular cells are highly connected to endothelial dysfunction and inflammation. And so all these risk factors, such as dyslipidemias, aging, diabetes, etc., promote endothelial dysfunction, which affect the constrictor tone, disturbed flow, vascular resistance, inflammation, thrombogenicity, etc. And the mechanisms seem to involve a dysfunction of redox signaling. So redox signaling to the shallow mind would appear to be bad. However, most of the studies that targeted antioxidants were without effect. So things tell us that the mechanisms are not as clear as just good or bad. And actually, in this case, there even may be a dark side of antioxidants. Look, for example, that in some cases, in some very specific circumstances, I must say, antioxidants can even, for example, accelerate lung cancer progression. And actually, they can accelerate metastasis in other models. Thus, for example, a test of vitamin E in a KRAS mutated lung cancer And you can see that the tumor burden increases with N-acetylcysteine and vitamin E, and the survival decreases with both. So that's an experimental model, of course. It's not clear to what extent these effects apply to humans, but considering that some people take indiscriminated amounts of antioxidants, this can have some potential implications. We have to pay attention to this. But if you have a mechanistic mind, what can you do? Then let's come back to the lab, study other ways to target this. And a more logical approach, for example, let's try to inhibit oxidant sources. And this is what has been done. For example, NADPH oxidases are enzymes that produce reactive oxygen species, ROS. ROS are oxidants, and they can be targeted by the production, by inhibitors of these enzymes. So that makes for a logical approach. And this is a very recent paper which has designed structure-based inhibitors. But before this could be done, so this shows a diagram of how complex NOXes are. There are several types of NOXes. I will not get into detail here, but just to show you how complex these protein complexes are, and the prior approaches of scavenging the oxidants after they were generated probably where it was ineffective, because among other things, you are scavenging the reactive oxygen species that are physiological together with those that are pathological. Now, this group here in C, they have studied the structure of NOXes. That's for the first time. It was a very, very difficult work that to crystallize the structure, and now they are designing new inhibitors that only target the pathological production of ROS. Will that be effective? We don't know. We have to test. This has to be tested, but this is how the future of medicine goes. We have some ideas. Sometimes simple ideas don't work. Then we come back to the lab. We crystallize proteins. We go to the structure of proteins, and then new inhibitors are designed, and the results can show more progress in this regard, but they need to be tested. Hopefully, some good things are going to come up from these new studies. And another point that I have to mention is that signaling, and we do a lot of signaling. Signal transduction is a transformation of a chemical signal, an environmental signal or any kind of signal in a chemical signal. And then we have positive regulators and negative regulators. So we always tend to think on positive things, effects are always the effects of the positive regulators, but they can be the absence of the negative regulators. So thus adds some complexity to those layers of reasoning. So modern medicine, in summary, can be defined as predictive, for example, genetic non-invasive diagnosis, preventive, which we try to anticipate to the natural history of disease, the disease progression and disease complications. It tends to be personalized. For example, pharmacogenetics tends to be multidisciplinary, involving multiple competences and larger teams, and as we have discussed it so far, tends to be mechanistic based. And now we have to start thinking more and more on molecular targets for therapeutics and diagnosis. And that makes room for our fourth message, which is that medical education needs reshaping to face the mechanistic and technological advances ahead of us. And the first reason is that things, signaling and metabolism, etc., are complex. So, for example, This is a metabolic map of the Kyoto genomics, genes and genomics initiative. And as you can see, the metabolic map is extremely complex. So we need education to tackle those very complex problems. The second reason education is important is we all know how a typical resident and postdoc feels nowadays. They are increasingly burdened with mental and environmental and society-related problems. And they are in a very special time of their lives. And if we want them to be good professionals, and a few of them go to the academic career, we need to care a lot about all those questions that are perturbing them. And the third point that is important for education is that innovative technologies bring novel problems. For example, diagnostic excesses, too much interventionists, high costs, a confusion between new and better, and they raise a fascination with technology from part of physicians as well as patients. So many patients start to demand from their doctors that the new technological advance is applied to them. And there are also several ethical dilemmas that are starting to come up regarding, for example, artificial intelligence and other things, and also very common, the prolongation of life. So how long should we prolong the life of elderly people? Because sometimes we can, but should we? We also have to face the push for questionable procedures and treatments. So complexity, problems for the young investigators and doctors, and problems with new technologies are very important reasons for allowing us education-related interventions. And I pose here that a scientific-oriented education is an objective way to help prevent these problems, because people are more objective. They become more methods-oriented, more evidence-based actors, let's call it that way. And I'll tell now two examples that are very interesting, and we can discuss them later. One is the MD PhD fellowship, and recently, since 2021, FAPESP, our foundation, Fundação de Amparo à Pesquisa do Estado de São Paulo, provides scholarship support for MD PhD. So it's a direct doctorate PhD degree starting before MD graduation, typically 3 to 3.5 years of duration, can be interrupted for up to 12 months for a training period abroad, but this training is supported by the foreign institution. The students have to have an excellent academic potential, and this is really in all areas of knowledge: clinical medicine, population science, lab research, and etc. And interestingly, the PhD degree only is effective when the students receives the MD degree. So that's a very, very in short, a way to support those students, because support for this program is very important. The program belongs to each institution, but FAPESP supports the scholarships from those institutions. And we know that the problem has been the lack of support. So those students want to get out to earn money to support themselves. But this scholarship is being a success, and it's, I think, a good thing to consider. The second example comes from Uruguay, actually, from Rafa's group, which is the course in scientific methodology for medical students, and Silvina Bartesaghi has been closely involved with this. It's a scientific methodology course for advanced medical students, and now the course has 8 to 10 years, I think, now, And it's a very interesting experience in which the students are here on the lower right corner, you see, they are subjected to 2 courses. One is the Scientific Methodology 1 at the end of 3 years. The Scientific Methodology 2, it's at the end of another 3 years, and then they have 1 year of internship. So in the, I won't read all this, but you can see that they, in the level 1 course, they are exposed to biostatistics, to methodological aspects, and to bioethical discussions. And they learn how to interpret the study, to make statistical inferences. They discuss methodological aspects, types of studies, types of reviews, for example, how to get a better evidence-based interpretation of results, how to read the literature, and of course, bioethical issues, which are very important. And as I alluded to in the previous slides, a scientifically oriented mind is a good way to prevent the problems arising from excess technology. The level 2 course, which is, as I said, at the end of the 6th year, has more advanced content on statistics, and now introduction to research and the scientific writing, and this is really accompanied by practical exercise, bibliographic search, and writing essay, and again, ethical discussions. And as you can see, from 2014 to 2021, there was a shift in preference from basic medicine and to specialized clinics. So all the fields of medicine are covered by these courses. And so we can see that the course is not only forming scientists. Actually, it's quite the opposite. It's helping professionals to be better physicians, practicing physicians, and to take science and critical interpretation to other frontiers. I think that's a very interesting initiative, and I am starting to discuss how to implement this. We have something that's not too different here in our university, but it's not as good and systematic as this one. And this is another important thing for education. I'm finishing now, which is you need to quantify results. There are several educational initiatives that are excellent, but their results are not quantifiable, and the experience is wasted over time. So in this case, we see that the team is being careful to quantify results and to measure the outcomes. Okay, we don't have time for the 5th message, but I want just to touch on it, which is a very important issue called implementation science, which is, okay, we know in the future we are starting to know more and more things, but we need to know how to transform those things into actions. And there is a science behind that called implementation science. How to transform what we know in what we do. We saw that during pandemics, for example. We know that vaccines are important, but some people don't take it. So how can we make people take vaccines, for example? How can we make people comply with medications? There is a science behind that we need to develop, and starting now, and it's a very important point to consider also in the translation from basic knowledge to practical applications. And in fact, advancing in education and implementation science involves in turn substantial basic science related to humanities, sociology, anthropology, which is starting to advance more and more nowadays. And it's a very important branch of medical sciences that need to be fostered. So there is a lot of basic science, not only in the laboratory, but here in humanities, sociology, anthropology, data science, and other fronts. So the take-home messages are that we don't know enough. We need to improve, to spread the culture that we are not doing well yet. We have advanced a lot, but not doing well enough. Basic curiosity-driven or mission-oriented science matters. A mechanistic mind will be more and more necessary for excellence in medical practice. Medical education needs reshaping to face the mechanistic and technological advances ahead of us. And implementation science is important, how to transform what we know in what we do. So this is just to tell you the team that works at our laboratory or has worked and is a continuous source of inspiration. And I thank you for your attention. Now,
Bueno, profesor Laurindo, muchísimas gracias por su presentación. Vamos a dar lugar a los comentarios del profesor Radi y les pido a los que están por Zoom que si tienen preguntas las hagan en el chat, así las podemos leer, y a los que están en la sala, después vamos a tener un micrófono para hacer preguntas.
Gracias Oscar. Buenos días. Bueno, en primer lugar, felicitar y agradecer a José Pedro Arcos, presidente de la Academia, por haber empujado y organizado, junto con otros miembros de la Academia y la Secretaría de la Academia, esta actividad tan importante. También a Oscar por compartir la mesa y por la generosa presentación. Y creo que la selección de la conferencia del profesor Laurindo como inicio de estas jornadas fue una elección muy apropiada. Desde ya saludo y agradezco a Francisco Laurindo, profesor de la Universidad de San Pablo y estimado y querido colega, por la brillante presentación que nos hizo, donde creo que genera una cantidad de elementos que a través de la jornada van a ir consolidándose y rediscutiendo. Me parece como que fue una muy buena presentación de las oportunidades y los desafíos que la medicina nos va a presentar en los próximos años y en las próximas décadas. Creo que cuando uno repasa el programa de las jornadas, eso está bien reflejado. Y sobre este asunto creo que, en primer lugar, las academias y la Academia de Medicina, en particular, colaboran a generar una atmósfera y un ambiente que es propicio a esta reflexión. De alguna forma va paseando la vorágine del día a día que nos impide visualizar cuáles son caminos superadores de futuro, ¿no verdad? Yo voy a volver sobre este tema en el contexto del Sistema Nacional Integrado de Salud en algún momento, que es un tema que nos ha preocupado desde esta academia y desde la Facultad de Medicina desde hace muchos años. Y ese ambiente y esa atmósfera que tiene que ver con los futuros desarrollos, con los componentes científicos, humanísticos, sociales y antropológicos, los tenemos que generar, por un lado, pese a la numerosidad creciente de los estudiantes que recibimos en la facultad, porque este año en la matrícula 2023 fueron cerca de 2.800 ingresos, 2.800 ingresos. Entonces, todo esto que estamos diciendo lo tenemos que trabajar en ese contexto de numerosidad, no como en el de la Universidad de Vanderbilt, con el profesor Marnet, que me reuní hace unas semanas, que me dijo, no, en Vanderbilt entran 100 por año. Es una universidad de 30.000 estudiantes, la nuestra tiene cerca de 130.000, obviamente somos mucho más grandes, pero el tema de la numerosidad es un gran desafío. Para poder, ya que se habla del desembarco del laboratorio en la clínica, para poder desembarcar todos estos procesos en los estudiantes que llegan a nuestra facultad en forma creciente año tras año. Entonces, ¿cómo generar y recrear esa atmósfera y ese ambiente de calidad y con una mirada de futuro, pese a esa enorme numerosidad, en un marco de infraestructuras de investigación y docencia y capacidad docente muy limitada? En el año 2000 aproximadamente se lanza el Proimbio. Acá está Oscar Novoa, está Hamlet, hay varios de nosotros, Eduardo y otros compañeros que hemos participado desde el inicio de la concepción, Javier Hurtado. Y el Proimbio, que básicamente es el programa de formación de MD, PhDs, la versión uruguaya de eso, está también Cristina Touriño. Es un programa estratégico para la Facultad de Medicina y para el futuro, el desarrollo de la medicina, y eso lo visualizamos colectivamente hace 2 décadas, pero es un programa que no ha logrado nunca un desarrollo con la potencia necesaria, primero porque eso es difícil en Uruguay y en el mundo. El tema de los MD, PhDs es una carrera necesaria, pero difícil de asumir en un marco de competencias de todo tipo que los médicos jóvenes tienen. Pero por otro lado, porque ha sido un programa que ha tenido grandes dificultades en cuanto a su financiación específica. Y cuando Francisco Laurindo nos plantea que en FAPESPI, que es la principal agencia financiadora del Estado de San Pablo, y en la escala brasilera, a nivel brasilero, que empiezan a partir de 2021 a generar becas específicas para el programa de MD-PhD, creo que eso es una acción muy concreta y muy correcta y que desde la Academia de Medicina podríamos y deberíamos insistir, y estoy seguro que la Academia de Ciencias y la facultad también se van a poner a orden. Porque no es lo mismo competir en un sistema nacional de becas cuando uno viene de programas como PEDESIVA, del cual soy parte fundacional, pero en este momento lo estoy mirando con una visión más amplia, donde el estudiante solamente tiene una actividad de investigación, con otro estudiante que tiene una doble función clínica y investigación. Obviamente las posibilidades de competencia están afectadas, ahí hay un hándicap. Entonces, ahí tenemos que tener acción afirmativa, y creo que debería generarse un programa o apuntar a la generación de un programa que sea protegido, más allá que también pueda haber una competencia general en el Sistema Nacional de Becas. Obviamente siempre es difícil reclutar buenos estudiantes para el proimbio, pero ellos sin duda pueden ser los futuros profesores de facultad, los futuros médicos que contribuyan a la incorporación del pensamiento científico en forma más decidida a la práctica médica. Entonces, por ahí me parece que hay un problema importante que no lo tenemos totalmente resuelto desde el punto de vista institucional desde hace ya más de 20 años. Con respecto al pregrado, han habido avances con el plan de estudios 2008, como se han indicado los 2 ciclos de metodología científica, y muy en particular el segundo ciclo, que culminó hace unos días con el 10º año de ese ciclo, donde realmente los estudiantes pasan por 10 meses por una experiencia inicial de investigación científica. Este año tuvimos 115 grupos, de 6 estudiantes cada uno. Eso está cubriendo unos 800 estudiantes de 6º año, implican cerca de 300 profesores que hemos participado, muchos de los cuales están acá, con lo que el esfuerzo institucional es muy grande. Ahora están surgiendo los primeros datos cuantitativos del cambio cualitativo que eso ha implicado en la formación de los médicos jóvenes, y esos datos van a estar disponibles en un futuro próximo. O sea, el primer corte de, bueno, pero esta experiencia, que teníamos intuición de que esto realmente funciona y subjetivamente todo el mundo dice, che, esta iniciativa está buena, realmente ha operado un cambio en la práctica médica, en la formación de los médicos jóvenes, en la presentación de trabajos a las sociedades científicas. Bueno, eso está ahora en proceso de medición, y esperamos que en unos meses puedan estar esos datos a disposición. Ya les digo que los datos preliminares son realmente muy alentadores y apoyan toda esta corriente de pensamiento que estamos todos acoplados y trabajando para eso. Pero de vuelta, el tema de la alta numerosidad sigue siendo un desafío y el personal docente está muy comprometido, pero esto notoriamente de hacerlo todos los años implica un esfuerzo y un compromiso renovado. En la medida que nos reafirme que esto es un camino valedero, creo que lo vamos a poder mantener. Francisco habló mucho de la medicina requiere el entendimiento de mecanismos básicos, y creo que al paradigma de la medicina basada en evidencia, que todos nosotros hemos acompañado, el Hospital de Clínicas y los servicios clínicos de la facultad han sido líderes en esto ya hace más de 2 décadas, pero obviamente que la medicina basada en evidencia, únicamente basada en un protocolo que se aplica para un paciente innominado, no es suficiente. Y ahí es donde aparecen las otras dimensiones de los equipos de trabajo, de la medicina personalizada, de aprovechar las herramientas básicas. Sigo pensando, no habiendo hecho prácticamente trabajo clínico en mi vida, que los aspectos semiológicos y clínicos tienen que seguir estando en el centro de la práctica médica, porque como dijo bien el profesor Laurindo, lo nuevo no necesariamente siempre es lo mejor, y la tecnología no necesariamente siempre da la mejor respuesta si no se abarca un paciente en el contexto. Y todos los que hacen clínica acá lo entienden mucho mejor que yo. Entonces, hay una preocupación, yo creo, creciente de la dificultad que tienen las nuevas generaciones en las aproximaciones semiológicas. Y creo que eso no debe perderse más allá de agregarle toda esta nueva capa de conocimiento científico. Yo creo que eso también tiene que ser un mensaje claro, que la medicina del futuro no necesariamente va a desvestir las buenas cosas que la medicina actual y la que aprendimos trae, porque en definitiva un paciente es mucho más que una patología, obviamente, y hay que mirarlo en un contexto general. En ese sentido, y habiendo grandes avances en distintas áreas de la medicina, como la patología cardiovascular, el cáncer, que se han logrado realmente superar una cantidad de escollos y que se ha mejorado mucho, nos quedan enormes desafíos. Estoy pensando en las enfermedades neurodegenerativas, en la enfermedad de Alzheimer, en el deterioro cognitivo que en poblaciones envejecidas vamos a ir viendo con cada vez mayor intensidad y para las cuales tenemos realmente muy pocas herramientas terapéuticas todavía. Entonces ahí hay que poner un foco en la medicina del futuro, pensar al Uruguay como un país con una demografía que cada vez va a empujar a poblaciones cada vez más añosas. Y ya terminando mi comentario, desde la Academia Nacional de Medicina y de la Facultad de Medicina, en repetidas oportunidades hemos hecho intentos para que estos abordajes científicos se integren como forma endógena al Sistema Nacional Integrado de Salud, como forma de desarrollarlo mejor, de pensarlo mejor, de tener procesos iterativos de mejoría continua. Eso no se ha logrado. La financiación para los proyectos de investigación clínico básica y clínica son escasos, el Fondo Sectorial Salud es marginal, los departamentos clínicos cuentan con enormes dificultades para financiar proyectos de mediano y largo plazo. Entonces creo que en el escenario de una agenda electoral 2024 que se abre, en el área de salud deberíamos volver a insistir que una parte de la inversión en salud retroalimente los procesos que tienen que ver con la medicina del futuro. Gracias.
Bueno, muchísimas gracias, profesor Ravi. Queda abierto para preguntas o comentarios, tanto de la audiencia como de los compañeros que están en el Zoom. Mientras surge alguna pregunta, a mí la verdad que la conferencia del profesor Laurindo fue muy provocativa porque nos hace pensar un poco en grande en vez de pensar en el campo de batalla, literalmente. Yo quería hacer poquitos comentarios, dos. Uno sobre la problemática para los que algunos definen a esas personas que son los que van a ser fluentes en ciencia y en medicina. Es decir, ese grupo de MD, PhD. Yo miraba que ayer en Nature salió un comentario sobre que esta es una especie en peligro de extinción. Y es una especie en peligro de extinción porque aún en los programas donde, como empezó a hacer en el 2021 la USP, el FAPESP, que es financiar, pagarle a la persona que va a ser estudiante de medicina y va a ser PhD también, eso lo hace hace mucho tiempo Estados Unidos y sin embargo hay un descenso permanente del número de personas que se aspiran a esos cargos, pensando que la carrera de medicina en Estados Unidos es de aproximadamente $40.000 al año. O sea, eso se lo van a pagar. Sin embargo, la gente tiene muchas dificultades. Particularmente a esto que decía Rafael con respecto al proimbio. Nuestros estudiantes se exponen en ese lugar a la doble condición de residentes de algún lugar, más estudiantes de proimbios. No hemos logrado poner el MDA PhD antes de la residencia. Y entonces cuando caen junto con la residencia, el desafío, que me encantó la imagen del mundo arriba del residente, además le pone el PhD. Y eso es como un desafío de resultado cero. Entonces es muy importante lograr anticipar a esa carrera, que tenemos muchos, grado 1, por ejemplo, que puedan hacer el MD, PhD antes de llegar a la residencia. Y ese es un desafío que además es difícil porque el desarrollo intelectual y de la complejidad del individuo muchas veces de sus preguntas fundamentales aparecen después de la residencia. Entonces ahí hay un conflicto que es difícil de resolver. Lo otro, yo tengo que decir que me he favorecido del programa de Metodología Científica 2, porque entre otros aspectos, una de las cosas que pasa es que los estudiantes se orientan a las especialidades a partir de ese trabajo. Y es un hecho bien importante para el desarrollo. Y finalmente, hay otro aspecto que es bien importante y que es cada vez más estamos llegando a esto que en algún momento había un editorial del New England de hace como 20 años que decía Medicina driving my medicine. O sea, cuando alguien pedía un estudio que no era necesario, muchas veces tenía un hallazgo que le generaba un problema y terminaba haciendo una medicina buscando ese problema que no había. Bueno, ahora cada vez más tenemos una medicina generada por medicina de otro tipo. La onconefrología, en mi especialidad, es de lo más característico. Nosotros precisamos conservar riñón para que el paciente pueda, conservar función renal para que el paciente pueda ser bien tratado de su enfermedad neoplásica y no empiece a tener limitaciones en su tratamiento vinculadas a la enfermedad renal. Y es, por otra parte, muchos de los tratamientos producen daño renal o producen daños que no tenemos previstos todavía, como muchos de los mecanismos de inhibición que estamos usando para el cáncer, que son generadores de enfermedades autoinmunes. Entonces, hay una medicina que estamos generando, que tenemos que conocer a partir de los eventos diagnósticos y terapéuticos que nosotros hacemos. Todos esos desafíos me parece que están muy bien englobados con la presentación del profesor Laurindo.
Bueno, muchas gracias al profesor Laurindo por una conferencia tan conceptual, a Rafael por bajar esos conceptos a Montevideo, Uruguay, y muchas gracias a Óscar por coordinar eso.